Hi everyone, welcome to this conversation with Professor Purendra Prasad. Today we are going to be talking about commodification of health and questions of inequalities. Before going into the conversation, let me quickly introduce Professor Prasad. He is currently teaching in the Department of Sociology at the Central University of Hyderabad. He has previously worked with the Center for Social Studies, Surat, and Tata Institute of Social Sciences, Mumbai. His research areas include agrarian studies, political economy of health and development, urban studies, and wealth inequalities. He is the co-editor of Equity and Access, Healthcare Studies in India, published by the Oxford University Press in 2018. Professor Prasad, I welcome you to this conversation and thank you so much for sparing your time.
No, thank you so much for inviting me.
So let me begin by asking you this question about how the laboring classes protect themselves from slipping further into poverty due to the kind of expenditure that they have to make if they fall ill. And this question is also emerging in the context of how the healthcare situation in the country has fared in the recent, past.
Yeah. See, sociologists actually study health and sickness not because they want to, understand the issues that are central to human existence in terms of suffering, pain, death, and impoverishment, etc. But it also helps us to, explain the organization of society. Okay, so for sociologists, this experience of sickness and disease is actually an outcome of the organization of society. For example, poor people living in poor people actually have always shorter lives, are prone to more diseases and vulnerability, while their counterparts at the top of the social system live longer. They actually have much healthier kind of a productive life. Okay, so in a sense, a lot of poor people living actually at the bottom of the social system always die of preventable diseases. Okay, forget about the major kind of chronic and other infections and communicable and other kind of diseases. Okay, so in that sense, for sociologists, why do people get sick? How do they get treated? And what are the kind of mechanisms they have to go through in terms of accessing healthcare? These are all actually not about their individual personality. It's not about their biological kind of makeup of the human body. No, it is largely about their position in a set of power relationships. Okay, so even when there is improved living conditions and medical practices, it does not automatically provide access to health services for all social groups. Okay, it's quite possible that if inequalities based on class, caste, gender, and ethnicity are not addressed, then it is not possible for actually the poorer people to improve their living conditions, primarily because disease and inequality are closely interlinked. So for your specific question, that we do know that increased cost of medical care is one of the second most important reason for poverty or impoverishment. Okay, and every year 3 to 4% of the people actually are pushed down the poverty line because of the expenditure that they incur on the healthcare. It is primarily because of the inpatient treatment, meaning hospitalization. Okay, and hospitalization on an average is very expensive. In India, 70% of the people actually go to private providers as their first line of treatment. And given all these things, it's very, very difficult. So how do they overcome? The only way is to organize themselves into more collectivities, build solidarities, work towards universal health care and right to health. These are ways through which I think the poor people can actually, overcome. But for sociologists, I think the analysis actually would be to understand how society is organized, gets more clear when you look at the disease and sickness and other kinds of dimensions.
So, in this context, how important would the role of the state and its intervention be in the improvement of the health status and well-being of, these classes?
Right. I think let me answer two pronged kind of a responses. One is to go back to the historical dimensions. Okay, so if you go back to the historical dimensions, we know that global flu of 1918. Okay, this helped to create national health services in many European countries. Okay, or if you go back and look at the crisis of Great Depression, Second World War, it set stage for modern welfare state. And at the end of the Second World War, when you look at the Britain, which was totally shattered, okay, in order to regain its economy and actually provide better kind of a health status to citizens, their public health system that was instituted led to what we are today actually hailing it as, national health service. The moment we talk about health service today, we all say that UK's NHS actually provides quality care for all its citizens, irrespective of class, caste, region, and other things. Okay, all these can be seen historically how state played a very important role in instituting certain essential kind of structures and systems. But if you look at the recent kind of a pandemic, the COVID kind of experience, okay, we do know that successful kind of experiments of local government system in Kerala through Kutumbasri, okay, the decentralized government system was very helpful in terms of tracing the patients, in terms of timely early detection of the cases, in terms of rational kind of treatment provision. Okay, all that, I think Kerala is a good example to understand how state can intervene more effectively. And similarly, Tamil Nadu is another very efficient healthcare model, which has two-pronged kind of a systems. One is public health, the other one is actually the clinical. So they don't mix up like other state kind of healthcare systems. So it's a very well-organized kind of a approach to public health that has a huge implications. Similar case in terms of Rajasthan, where they provided free drug supply that actually provided a lot of help for the poor people to improve their health condition. Okay, so in a sense, state actually plays a very instrumental role in terms of achieving equity and social justice. Okay, so if the poorer sections of the society will have to improve their kind of a health, okay, state intervention becomes very important. And given that private healthcare is very expensive and out-of-pocket expenditure today, okay, is about 70% on an average. Government spend only 30%. Most of the expenditure is spent by the people from their pockets. Given the situation, I think state plays a very important role in providing that kind of a support networks and access to healthcare for especially the lower classes and subaltern groups.
Right. And with the state, there's also a burgeoning private healthcare sector in the country now. So how would you locate the growth of this healthcare sector, which is very private in nature, in this context? And, how should one assess it from a sociological point of view?
Right. That's an interesting dimension that we are all encountering, of course, across the world. I think private healthcare and corporatization of healthcare has become the in thing. See, especially in India for the last several decades, what happened is states' commitment to social welfare and redistribution of benefits of economic growth, okay, have been replaced with the neoliberal logic of encouraging the private enterprises. And politics and health policies in India have moved more towards a pro-business kind of a model. Okay, So if you look at post 1990s, it marks a very distinctive kind of a neoliberal phase, and it has impacted very strongly in terms of health, education, and other social sectors. From 1980s onwards, this contradiction between hospital-based kind of a healthcare has been privileged over primary healthcare. Okay, and you can see by 2022, the estimates are that the hospital industry has grown to about $8.6 trillion in India. Okay, and in fact, this is evident with the way health sector or health industry has emerged as one of the largest businesses in India. And during COVID period, the number of rich people has increased, okay, from 102 to 140 rich, okay. If you look at Covishield Serum Institute, Cyrus Poonawalla, whose wealth in just 2 years actually has been increased by 74%. Okay, so given this kind of a corporatization of health, where hospitals are established increasingly in the post 90s as companies, private companies investing in healthcare, essentially to improve profits, dividends to shareholders, and the public listed companies are being set up. It is all about the stock exchange and listing of hospitals in the equity markets. Okay, so these changes actually have not merely established corporate hospitals, but it has actually established a corporate culture. And that will have a huge impact on the different social groups in India. Okay, so in that sense, the private kind of corporations, okay, have also led to unethical medical practices and increased kind of surgical interventions and all kinds of corruption and other things have actually increased. So this is where the privatization and corporatization actually has led. But one is not saying that privatization or private healthcare actually should not be there, but the problem is unregulated private sector. And that in the health sector seem to be having disastrous consequences on the human bodies and well-being of the large population.
So Professor Prasad,
Yeah.
would you be able to speak a little more about the corporatization of hospitals, as well as the way in which the private healthcare sector is unregulated,
Yeah. Corporatization of hospitals, actually, it's interesting. The first corporate hospital in India was established in 1981 with Apollo Hospital actually coming in Chennai. Okay. And Apollo Hospital actually came up with an assurance that, all the specialities actually are all under one umbrella. And state at that point in time, Pranab Mukherjee, who was finance minister, and Indira Gandhi, who was the prime minister, gave a green signal and also tried to encourage all the state governments to give land free with an MOU that they will provide at least a 10% free treatment in all the private hospitals. But the state actually also gave a lot of subsidies for the for the import of medical equipment. I think they actually subsidized, so provided land, gave a lot of incentives, import duties were actually given off, but none of the clauses that they have agreed, saying that they will provide free treatment to the poor or they will provide a database to the state, none of these things actually happened. Rather, after these private hospitals and corporate hospitals actually have deeply entrenched, usurping the middle level and smaller kind of private clinics. Now, in the post 2000, their demand was that state should actually also provide the patient pool because they have invested huge money on the medical equipment. And that's how the insurance-led programs which came into existence, primarily like an American kind of an insurance model. The only difference is that here premiums are being paid by the state governments and the union government. Okay. So corporate hospitals in the post 2000 are not only talking about insurance model, but it's all about highly surgical kind of intervening kind of healthcare, which is dangerous for the overall kind of a well-being of the society. Okay. In fact, just an anecdote here. Okay, that a lot of researchers have commented saying that if you find within a nation relatively, lesser kind of a difference between the rich and the poor, okay, and if there are more people who are able to access, primary health care and preventive kind of a thing, those nations are actually very healthy. Okay. So given our kind of a condition, with more and more corporatization of healthcare, more and more insurance-led programs, out-of-pocket expenditure has not come down. The institutions actually have enhanced enormously in terms of controlling and regulating everything to their advantage. Okay. So this is where one could see how corporate healthcare actually has led to iniquitous kind of society, and that is impacting different social groups tremendously.
One more thing that we often hear of today is, of course, health insurance.
Yeah.
So, how would you assess its role in increasing access and reducing health expenditure? Has any substantial change actually happened on that front with the coming in of health insurance?
Right. As I said, post 1990s, India witnessed entry of large-scale capital into health sector because of allocation of, as I said, prime land at low rates, exemption provided, tax duties, and all kinds of importing drugs, high-tech kind of medical equipment that was actually provided incentives. So that was the 90s and 2000s. But post 2000s, particularly post 2007 and 2008, you see insurance-led healthcare model actually has come as a major kind of a model in India. Okay. All the governments justified saying that at this point in time, we are still committed to improving government healthcare system, but there are thousands and lakhs of tenants, farmers, workers who are not able to access a lot of treatment because those equipment is not available in government hospitals. So till then, till we improve, we want to provide access to corporate hospitals also to the poor people. This is the justification that insurance-led kind of a healthcare model has come. But having come, now that has become increasingly the only way. If you see from time to time, they keep actually announcing that there are more procedures that are included in the health insurance. Okay. To just give you one example, hysterectomy, which is part of the procedures, was hugely misappropriated, and a lot of women actually were forcefully actually had to undergo because there is insurance that is provided. Okay. And in one or two states where there's a lot of resistance from below, they had to drop that hysterectomy as part of the procedures. Okay. Similarly, recently they have opened out normal deliveries and cesarean C-section to private hospitals where government will pay. Okay. This has actually also studies indicate that it is costing 3 times for the government to actually let this procedure go out to the corporate hospitals. So it's not about providing more access. It is about providing more kind of a benefits to the private sector. Okay, so this is where one could see in the post 2000s, okay, there is proliferation of these corporate hospitals, okay, and they have actually lobbied and influenced range of procedures as part of it. And given that there is a heavy reliance of people on the private sector, government hospitals are getting weakened and weakened because the existing health budget actually is diverted. The resources are siphoned off by the corporate hospitals. Okay. And they actually pick and choose only those procedures which do not actually require people to stay beyond 3 to 4 days in hospital. Otherwise, rest of the procedures, they actually ask the patients to go to the government hospitals because it is not viable. So this is a profit-driven kind of a model rather than providing treatment and providing kind of a health to the population. And unfortunately, as Christopher Jofferlot says, state and the business corporations actually have the nexus actually has gone much deeper in the last 2 decades.
Right. And in one of your papers, as I was reading, I also found out that you characterize the Indian state's health policy as that of a double movement. And I was just interested in knowing more about it, that why do you do that? And, what are the reasons behind it?
Yeah. If we talk about Indian state, generally we get, when we want to talk about broadly in terms of the post-independent period, the 2 phases. One is probably something like a kind of a socialist welfare state, okay, or what is called as Nehruvian state. And the second phase is the neoliberal state. Okay, this itself actually corresponds to what Polanyi talks in terms of the double movement. Okay, so for Polanyi actually is very clearly indicates that how state concentrates on both the ends of the spectrum. Okay, one the poor and the rich. Okay, what it suggests is that in terms of protecting the poor or bringing out certain populist and social protection policies for the poor, simultaneously it actually encourages and hugely backs up the business houses to accumulate capital. So in a sense, Indian state has been pursuing aggressively in the health sector very hegemonic, dominant, market-oriented policies on the one hand. At the same time, articulating some kind of a community health discourses. Okay, in that paper that I wrote, State and Health Markets in the times of pandemic, you can see, even during the neoliberal phase, it brought in NRHM, National Rural Health Mission. It actually constituted a committee to look at the universal health care. Okay, and it also talks about the 2019 health policy documents talk about health as right to health. Okay, all the discourses that actually provides some kind of a radical kind of a language in terms of the poor and the vulnerable, state talks about it, but it implements exactly the opposite in terms of promoting the private enterprises and business houses. Okay, to just give you one other example, I think Niti Aayog, the think tank of Government of India, is talking about why we should not privatize all the district hospitals, particularly their land should be given out on lease to private hospitals on a 33-year or 99-year kind of a thing. And this is a Niti Aayog document actually is talking about. So in a sense, the double movement here, what Polanyi is talking about, okay, it constantly, is designing certain kinds of insurance-led programs, some kind of a populist kind of programs, NRHM, which talks about emphasis on primary health care, Okay. But on the other hand, it only talks about opening the doors hugely to the corporate houses in many ways. Okay. So that's the double moment in which it is in the name of protecting the poor, it actually is siphoning off the government resources and providing the patient pool to the corporate sector. So that's the double moment that one could actually see in the Indian health sector.
Last question. Could you also comment on how the private and the public healthcare models have unfolded during the pandemic, as we are speaking?
Right. Interestingly, the government sector, which has only about 27% inpatient facilities, meaning beds, okay, was actually overcrowded. It could not, withstand the kind of pressure during the COVID period. Okay, it crumbled, and still, I think the public sector with the 27% bed facility was able to provide a large kind of treatment to the COVID patients, whereas the private sector, which has 73% inpatient facilities, was hardly able to provide 10% treatment to the 10% of the COVID patients. So that's the paradox that one could see with huge kind of inpatient facility and modern kind of equipment and super specialty hospitals. It was not able to actually, cater, because it is driven by the logic of the profits, even during the crisis, even during the pandemics. Some state governments like Maharashtra, Karnataka tried to impose certain ceiling on the private hospitals and super specialty hospitals during pandemic. But these, the regulations by the state governments have been again circumvented, okay, by inflating bills on other kind of, PPT kits, or other kind of gloves and doctor consultation and all kinds of things. Okay, a lot of studies, one study conducted in Maharashtra says that the inflated bills in private hospitals were exorbitant. In fact, 75% of the private hospitals experienced overcharging in tune with the official charges. Okay, so that's one example that one could see during COVID, what happened with the public sector and what happened with the private sector. Okay, second example is, while there were a lot of vaccine public sector units which were competent, which could have produced the vaccines, Indian state decided to only give it to the two private companies, okay, Bharat Biotech and the Serum Institute. And the way those vaccines actually were produced, the distribution and the pricing mechanism, okay, with all the support that government provided, there was no limit or ceiling on the price mechanism. In fact, government was willing to go with these two private companies to market it. Okay, so this was all something that one could see from 2015 onwards, how some of these biotech labs were taken over by some of these vaccine companies, which led to monopoly of the vaccine production, and that has actually optimized the healthcare. So in a sense, even during crisis and pandemic, okay, the state was not only willing to actually provide support to the capital accumulation strategies, but it was also trying to not strengthen the public health care. Okay, so that was the time when a lot of middle classes and upper middle classes were also were talking about government hospitals, because they did not have any other option despite having some kind of resources, etc. Okay, so why is it that state actually favors corporatization of healthcare? That's primarily because it reflects the class interests. And this is where, as sociologists, I think we try to understand, okay, whether it is health sector, education sector, law and governance, gender and development, any of the domains, what you see is that the way certain of these actors, the nature of state, the class nature of the state and its kind of actors, all this is evident. So it's not a question of whether it is health sector or education sector, but what we need to understand is how society actually reorganizes itself from time to time. And as sociologists, it's important to understand these social realities from different perspectives. Within sociology, you have Marxian framework, you have Parsonian or functionalist kind of a framework, you have Foucauldian framework, you have Marxist feminist and feminist kind of frameworks to analyze the relation between medicine, health, and society. So this is what I thought we want to look at, because pandemics and how pandemics actually unfold themselves, and how this crisis actually is created as though it is actually suddenly erupted. If you see the deeper kind of a link between agribusiness companies and that of the way the animal population and the other kind of inhabitation that's going on, it's quite evident that for quite some time you have a lot of these risk producing conditions that corporate kind of networks that globally they're operating would actually contribute to the disease burden and vulnerability for the larger sections of the population.
Right. So thank you so much, Professor Prasad, for throwing light on some of these very important issues on the sociology of health. And once again, on behalf of Doing Sociology, I thank you for giving us this time and opportunity.
No, it's my pleasure. Thank you so much for inviting me to share some of my ideas. Really, I appreciate your efforts in doing this. Thank you.